Broadly speaking, how you treat small cell lung cancer is largely either a single nodule and plus minus one lymph node that's really out to the periphery that might be treated with surgery, followed by chemotherapy. More broadly, and that's an uncommon scenario, this is something that would be more commonly picked up in something like lung screening. More commonly, though, limited stage ends up being a lung mass and lymph nodes, often in the middle of the chest, but nothing beyond. And if it's all limited within that area, it's considered potentially curable, and it is treated aggressively with chemotherapy and radiation. If you're talking about limited stage, then the treatment goal is cure, and that's chemoradiation. Now, there were studies done that incorporated immunotherapy. We don't yet have the results of those. I'm optimistic that that's going to show positive results, but we'll have to see. I don't know when that data will be available, but I can't imagine it'll be too much longer before we get something. But right now, chemotherapy and radiation together, and then you talk about radiation to the brain, prophylactic cranial irradiation. Everyone here and online may already know this, but usually when I'm seeing someone in the office and they've just been diagnosed and we're talking about chemotherapy, I'll often make the comment that many people picture that with chemotherapy, they're going to be laid up in bed vomiting without hair. And often people respond, well, that's exactly what I thought it meant. And now the chemotherapy for small cell, people do lose their hair. But thankfully, this whole idea of being laid up vomiting really broadly does not happen. Our anti-nausea medications are so good that that's not typically an issue. Now, that's not saying it can't be, but broadly speaking, it's not often what people picture. So the chemotherapy with radiation is the way that that's treated. Now, a separate topic is radiation to the brain, which we can potentially touch on. That's become a bit more nuanced and is certainly worth discussing with a radiation oncologist, whether or not to get radiation after finishing chemotherapy in extensive stage or chemotherapy and radiation in limited stage in both of those. But that would be the treatment for limited stage. Now, extensive stage, we've had a big advance, really about 5 years ago at this point. Now, extensive stage is spread beyond the chest, essentially, or too much to fit within one radiation field. So it's more than you could encompass with that very aggressive treatment we talked about, chemotherapy and radiation. And that is now treated with chemotherapy plus immunotherapy. Now, immunotherapy has been revolutionary, not in the treatment of everybody, unfortunately, but a subset of individuals that really have ongoing extraordinary disease control in some cases. And I'll go so far as to say, I think that there are some individuals that are actually cured of this incurable diagnosis when it is stage 4, when it has spread, with the incorporation of immunotherapy. We see people that are sometimes many years now out. Now, first approved about 5 years ago. I think we need another 10 years before we can really say what kind of long-term control, because people just started getting it 5 years ago. But we do see people that are years in from initial diagnosis now. For metastatic disease, for stage 4, then it's chemotherapy plus immunotherapy. Now, there are certain other diagnoses that could make it very high risk for giving immunotherapy. These are things like autoimmune diseases. So if someone is seeing a rheumatologist and on treatment for some kind of autoimmune disease, rheumatoid arthritis, Crohn's disease, things like this, then in those cases, the immunotherapy might not be recommended. That being said, if the diagnosis is something that for years has not required any active management, then maybe the immunotherapy could still be utilized. And that gets into some specifics that really requires meeting with your doctor to talk about those.